Hey now, I'm Jack Cush, executive editor of RheumNow.com. It's the 17th of March 2017. This is the RheumNow Week in Review. Highlights on this week's news include a report on hepatitis C and the use of DMARDs suggests that hepatotoxicity may not be as great as you might imagine. There's also a report this week from the AAOS, the orthopedic meeting in San Diego, that says that some of the most common things that we do in leading up to joint replacement surgery may be a waste of time and a gigantic waste of money. And lastly, there's a lot of reports about more gout, and the undermanagement of gout, and we'll review all of that. First, there's a report about post-streptococcal reactive arthritis. I see these patients, I'm sure you do as well. They tend to be seronegative new onset arthritis, usually oligoarticular, sometimes polyarticular. They have serologic evidence of streptococcal infection with an ASO. They tend to be hard to treat and not very responsive to non-steroidals. These patients, although they have high ASOs or streptodornase levels or whatever test you may be doing, they don't have sore throat, they don't meet Jones criteria, and they don't have carditis in the vast majority of cases. The question is whether or not to give them antibiotics as chronic therapy. I try, and sometimes you actually have success. There's a nice review and a case report that we've cited. Helio has a nice article that reviews REMS. This is the risk mitigation strategies that drug companies have to employ when they introduce a new drug that may have certain risks that the FDA is very concerned about. So these become mandated safety measures and programs that the companies must employ with certain new drugs. You may see REMS referred to from time to time. I think review of this might help you understand this. Another interesting report looked at persistence on a TNF inhibitor amongst patients with psoriatic arthritis, specifically 1,241 patients who started on a TNF inhibitor, and they showed that the factors that were most predictive of persistence on a TNF inhibitor included being TNF naive, having more skin involvement, more prior DMARD treatments, and moderate to high disease activity. I find that all surprising. I would think that, yes, new disease, but really bad disease, more skin, lots of DMARD failures, high disease activity. I would think that that might be a recipe for failure, but it turns out that those were predictors for staying on drug longer. A study of 92 patients with DEC scanning and gout looked at the association between urate deposits, soft tissue signals around the urate deposits and the development of erosions, and showed that there was actually about an 80% agreement between the development of erosions and the proximity of tophus and soft tissue swelling, suggesting that, again, it is probably the urate deposition that's eroding that cortical bone in patients with tophaceous gout. A reminder from practice, don't miss hypermobility syndrome, especially in young people. I like to end the visit with, hey, can you do any circus tricks? Or can you do anything unusual? I have a kid that actually, I've had two people now, they take their Adam's apple and they like slide it out here about 2 inches, and then it sort of springs back into place like a cartoon character. Funky, but these people may very well have hypermobility syndrome, Ehlers-Danlos syndrome, and that may be the cause of their underlying soft tissue and joint complaints. Many of them have coexistent fibromyalgia. Two interesting studies from a VA cooperative study looking at 748 RA patients who have hepatitis C. These patients have well-controlled disease, they have low viral loads, and they don't have LFT elevations. And specifically, they looked at when you give them DMARDs and biologics, do those drugs cause hepatotoxicity? And using a measure of greater than 100 as an ALT or a log higher viral load as an indicator of hepatotoxicity, they found that hepatotoxicity, in fact, was really quite uncommon. 3.4% would have an ALT elevation. And more interestingly, they found that it was these hepatotoxic events were more likely with biologics than with DMARDs. Now, again, they were very low frequency events, but when they did happen, 75% or so happened within the first 6 months of the drug being introduced, suggesting the need for close monitoring in patients who have hepatitis C with RA who go on such drugs. A nice report from Corona, a tremendously large database, actually, I think, does a good job proving the point that there is a window of opportunity. I've always said that that's a chronological construct wherein an intervention would have a meaningful outcome and delay the onset of more severe disease. In their specific study, they looked at patients who were starting on abatacept, and they showed that patients who had a shorter disease duration was associated with a greater change in CDAI and a greater percentage of patients achieving low disease activity when they received abatacept, suggesting that the earlier, the better, reaffirming that, again, diagnose early, treat aggressively, treat early. There is a window of opportunity. A great review of gout is published by Rob Keenan from Duke. A lot of good points in there. Gout, I didn't know this, but just between 2005, 2011, the cost of gout in the U.S., $31.8 billion. In 2002, there were 3.9 million patients seeking care for gout. Those were outpatient visits. And for those who did seek care, this is a study by Krishnan and Dan Solomon and a few others. Only 1.3% of patients seeking care, the care was delivered by rheumatologists. We need a bigger role in managing gout. A review of alopecia areata and the use of tofacitinib. Tofacitinib has had sort of magical responses in the very rare and very severe case of alopecia universalis. It turns out that's part of the spectrum of alopecia areata, where they have very, very mild hair loss or total hair loss, the universalis patients. In their review, this is, I think, the Yale group actually is doing these studies. They showed that when you give Xeljanz, 20% of patients achieve total hair regrowth, 20%. But equally as well, 58% showed a greater than 50% degree of hair regrowth, and then 77% showed some degree of hair regrowth. So 3/4 of patients will respond, half will respond really in a major way, 50%, but only about 20% will have total correction of their hair problem. The FDA has actually delayed its decision on a new drug. We're certainly aware of the use of Forteo, teriparatide, which is going off patent, but now we have the new anabolic drug, abaloparatide, which is about to be, we believe, FDA approved. Some really impressive studies showing its efficacy in a lot of different clinical osteoporotic situations. The FDA is reviewing this. The drug comes from Radius. There's been a 3-month delay in the FDA decision. This is largely going to be based on the need for more answers to questions that the FDA has posed to the sponsor. There is a study from France, the Espoir study, which is an early RA study of 602 patients that actually looked at patients with early RA who started on a number of different therapies. They followed them for 7 years. They did see in that cohort 2/3 of the patients who were started on low-dose prednisone. And a review of the effects of low-dose prednisone in these early RA patients following them out 7 years showed that low-dose prednisone was not associated with more adverse events, not associated with more infections or hypertensive episodes, and it was, however, associated with more drug use, suggesting that patients who got low-dose prednisone were also more likely to receive more therapies and more aggressive therapies. This week at the AAOS meeting in San Diego, there's an interesting report that some of the high prevalence interventions that we use in patients with knee osteoarthritis prior to their having knee replacement actually have low value and no effect. The orthopedics groups go on to say that up to 1/3 of the costs that are expended in that period before they have surgery can be a sizable cost and is totally useless. Specifically, they say that the use of intra-articular steroids, intra-articular hyaluronic acid, and physical therapy accounts for almost 53% of the total cost of care prior to joint replacement. 2 of those 3 are not recommended by the Orthopedic Society, the AAOS, and that means specifically the intra-articular hyaluronic acid and intra-articular corticosteroids. Interesting because many of us do rely on those, and certainly even orthopedists rely on those to manage their patients. There is an interesting report that came out this week in a number of different places about the change in work schedules for residency programs, specifically for interns. This appeared in the New York Times and many of the major news outlets, and the new rules actually have been changed by the ACGME, who oversees residency training programs, citing a number of different studies that have studied the effect of limiting the number of hours that a young doctor can work. As you know, many of this stems from the Libby Zion case over 30 years ago, where it was thought that overworked, underslept young physicians make mistakes that can have lethal and morbid consequences. That led to a restriction in hours where young docs could only work 16-hour shifts when they were on call and had to be off the next day. And this created a problem in patient management. Turns out that when you look at this in a number of different studies, they showed that there was no safety downside when hours were restricted, but that the greatest amount of problems and safety issues occurred with the handoff of patients, and that the frequent handoff of patients from the doctor who knows the patient to the doctor who doesn't know the patient and is covering led to more mistakes, led to more problems, hence the lift of the ban, and now young docs can work 24-hour shifts and as much as 28-hour shifts. These new rules do not affect the hourly limits on residents, who generally have a 24-hour limit as well. Also this week on RheumNow, we had, actually today, we published an article about the, get my computer going here, about the problems of undermanagement of gout. As you know, I mean, gout is, as we said earlier, only managed by 1.3% of rheumatologists. And that's a shame, since we're the supposed experts of this condition. But you know, there's many things that you should know, and to take responsibility for gout, if you look at the article, you'll see some of the statistics which are really shocking, if not sobering. Again, 3.1 million people in the United States, there's 8.3 million people with gout, 3.1 million are on urate lowering therapy, but the number of patients who are actually being monitored for urate lowering therapy is shocking. And like somewhere around 30-40%. In the UK and Sweden, there are very, very low rates of urate lowering therapy use amongst patients who have gout. Of those who are on urate lowering therapy, the goal is what? 6 or less as far as uric acid. Treat to targets become the mantra. Yet, only 40% or less of patients who are being treated with urate lowering therapy are achieving a uric acid level of 6 or less. Treat to target isn't working, or at least people aren't paying attention to it. Hyperuricemia affects 43 million Americans. The consequences of hyperuricemia are dramatic. Its associations with heart disease, heart failure, renal disease, hypertension. It's hard to make a direct connection, and there's an argument about whether it is directly connected. It is certainly associated with nephrolithiasis and renal disease and gout, but is also associated with metabolic syndrome. More so now than ever, I'm treating asymptomatic hyperuricemia because of what it may do to the heart and the vasculature and the risk of cardiovascular disease. Again, the statistics that are on here are dramatic. Maybe the one that you should know is that in the US and Canada, hospitalizations for RA, rheumatoid arthritis, have declined with better therapy, but gout hospitalizations actually have not. They've gone on and continued to increase, in fact. More importantly, the mortality gap, meaning that has been closed in RA. The general population has a mortality rate. RA patients used to have a much higher mortality rate. That's gotten better in recent years with more effective therapy. The mortality gap has not changed in patients with gout, suggesting we're not doing a very good job of managing gout. And that's a crying shame. So there's a lot that's on about the undermanagement of gout. You should look at that. A few last items. The FDA has invited open commentary on the issue of biosimilar interchangeability. We reported this on the website. Now is the time you can go and you can put in your comments in an open forum for the FDA to read. Look at today's report. We'll give you some guidance on what you should write about, some of the issues you may want to consider. There are a number of considerations that are important. So, for instance, you know, the validation studies, should they be unilateral, going from the biosimilar to the original to the biosimilar, or should it be bilateral, going back and forth from being on the biosimilar to going to the originator and back? Is that safe? What about the issues of immunogenicity when that happens? What happens in people who are having changes in their insurance? What should be the role of the pharmacist here? Should he be the one that's actually making these changes because it's mandated by their insurance company, or need there be physician sign-off and patient agreement? Should this apply to all patients on the originator reference product, or should this only be for new biologic starts? There are a lot of issues here that will affect rheumatologists, ones that you need to be aware of. Lastly, there's Wine and the Rheumatologist, the great blog, repeated blog by Lenny Calabrese. To read this is to actually go to dinner with Lenny and sort of get the ambiance, get the smell, the woody, soapy, whatever the words they use for wine. I'm not a wine person, but when I read Lenny's blogs, I feel like could be a wine person. I mean, he's talking about a great bar and restaurant in Phoenix called Trotto, which is a descendant of Pizza Bianco. He has dinner with Peter Lipsky. They have a glass of a wine that I can't pronounce, a Negroni something or other. You know, he talks about the wine with the dinner. The preemie course is a Farinita, which is kind of a chickpea pancake, slightly crusted with a pillowy outside. He says, ding, 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 round one is a winner. The Secundi, the second course. He has a test. He tries the Cape e Pepe, a classic Roman dish with pasta, pecorino, cheese, pepper, and some butter. And he, again, ding, ding, ding. Again, if you read this, it's sort of like being at dinner with Lenny. It's really wonderful, worth a read, worth reading all of his blogs on rheumnow.com. You should also know about Lenny's running a conference that's going to occur at the Cleveland Clinic. If you've never been to the Biologic Summit, Biologic Therapies, this is the 7th summit that he's had. It happens every 2 years at the Cleveland Clinic. This year's it's going to be April the 5th through the 8th. A wonderful meeting, all the leaders in the biologic world talking about all the issues that are really germane to practice, really germane to drug advancement, are going to be discussed in the course of this 3 or 4 day meeting. I'm going to go. I hope to see you there. That's it for this week at rheumnow.com and our week in review. You can go to the website and look a lot of these citations and find the references if you'd like to read more. We'll talk to you next week. Enjoy your weekend and have a great next week.